Hello, everyone. My name is Josh Liao. I'm a physician and an academic faculty at the University of Washington, where I co-lead a program of research and evaluation studying things like payment models, such as bundle payments, and their impact on care, including that in the post-acute period. I'm excited today to share a little bit about this topic, the impact of bundle payments on rehabilitation services and other post-acute care. Just before we get in here, I wanted to say that the views that I express today are those that I hold and don't necessarily represent the views of my employers or any groups that I'm affiliated with, and that I do receive grant funding from several groups, including the National Institute on Minority Health and Health Disparities, as well as the Agency for Healthcare Research and Quality, for projects that study payment and equity. So a few takeaways here. I want to begin with the end in sight. And what I hope to leave you with during our brief time together are a few things. The first is that bundle payments as a payment model have demonstrated cost savings and stable quality for both surgical and medical episodes. The second is that savings driven by these payment models include changes in rehabilitation services with slightly different mechanisms, I'll say, for surgical versus medical episodes. And that these effects that I'll describe can really exist for individual bundle payment programs, but also in circumstances where bundle payments may overlap with other payment models, such as accountable care organizations. Okay. So with that said, just a very quick level setting about what bundle payments are. On the left here, you see a figure in which there is a cohesive arc of clinical care where things like pre-admission services, the hospital services, inpatient physician services all stick together from a clinical perspective, but the payment is piecemeal and not necessarily put together. And so a bundle payment, as the name suggests, seeks to bundle the payments for those services that stick together into one bundled payment. And so this payment model sets a target price for those services and then seeks to create an incentive around it, whereby clinicians and organizations that participate, if they achieve cost efficiency and quality, then they are able to achieve some financial bonuses because of that. So that is, in a general sense, what bundle payments are. The details differ by program to program. And this, in fact, is something that colleagues and I have been working on over time. And we describe how there are different ways that you can define a bundle. So there's no such thing as a monolithic bundle payment. A bundle can be, in fact, defined in different ways, depending on how you want an episode to begin and end. And here you see three options. Option A defines an episode, or a bundle, I should say. This slide just shows three different ways that you might define a bundle payment episode. Option A shows an episode that begins with hospital admission and then goes through discharge and out through some period of post-acute care and encompasses post-acute services. Option B has pre-acute services and hospital services bundled. And option C is perhaps the most narrowly defined episode, which is hospital services, admission to discharge. And when we think about bundle payments, I would say option A is by far the most prevalent in this country, but in the general sense, there's no reason why it has to be defined that way. But to date, it has been defined in this format. And probably the flagship program when we think about bundle payments across the country is this program called BPCI, the Bundle Payments for Care Improvement Initiative, which was organized and launched by Medicare, and to date is the largest completed or concluded Medicare bundle payment program nationwide. It ran from October of 2013 through September of 2018. Just a few things about this program, because this is the basis of the data I will show you today, and I think yields learnings for all of us who are interested in understanding how bundle payments affect post-acute care and rehab services. So BPCI, there were multiple different participation options, but the most prominent is what was called Model 2. Model 2 involved a fixed target price for episodes that span from hospitalization, so admission, through discharge and out to 90 days of post-acute care for a collection of 48 different clinical episodes. So it was the option A that I showed you several slides ago about how to define an episode. In terms of the different episodes, as I mentioned, there were 48 different episode types that were included in this program. But far and away, the most frequently enrolled was this lower extremity joint replacement, so surgical replacement of the hip and knee joints. In this model, represented at one point over 35% of all episodes. So what was the impact of this program? What was the association between BPCI Model 2 and episode outcomes across, say, surgical and medical episodes. So colleagues and I led an evaluation of these very issues. And the first I'll show you is, given that lower extremity joint replacement was so high volume in this program, the first study we looked at was, in fact, the association between this program, BPCI, and surgical episodes looking at joint replacement. I won't get into the details here, but we used, I think, what is widely used as a quasi-experimental difference in differences approach. There were a few things that we did in particular here using an instrumental variable and other quasi-experimental methods, but suffice to say, kind of observational analysis using quasi-experimental methods to try to tease out the relationship between this program and episode outcomes. So using that general difference in differences framework, what did we find? Let me get right to the punchline here. And what you're looking at is a forest plot showing the difference in differences adjusted analyses, where we look at hospital participation in BPCI model 2 for joint replacement episodes and outcomes. And here you're looking at the spending outcome. Just to orient everybody, this will be a recurring format for the figure you'll see in our time. But on the x-axis, you have the units of spending, in this case, differences. And so that dotted vertical line at the 0 mark, if the point estimate, the diamond, or that confidence bar crosses that, then from a statistical significance perspective, I and colleagues would interpret that as being kind of no difference. Point estimates and bars to the left in this view suggest differentially lower spending or differential differences in spending as cost savings. And then conversely on the right, if you saw a point estimate and bars to the right of that 0 line, you might say that was differentially greater changes in spending. So what I take away from this figure is that if you look at all hospitals, the entire study period, if you kind of break that into the early period and the late period, if you look at it in terms of not the period, but also which hospitals get in the first early entrants versus those who came in later, what the story I think here is to say is that there is an association between this program and episode savings for lower extremity joint replacement, that those savings are driven early in the program period, in that early BPCI period you see there, and are driven by early entrant hospitals throughout, as opposed to late entrance hospitals, right? So top line here, that there are cost savings or episode savings associated with this program. What about quality? And when we looked at those outcomes, we saw that there were no differences in readmissions, emergency department visits, joint replacement complications, and mortality. When we zoomed in a little bit on the spending, we said, okay, the spending, there's differentially greater decreases in spending. Where is it coming from? So here you're looking at spending components, and you're looking at among episode spending components, you have hospitalization, readmissions, SNF, skilled nursing facility, inpatient rehab facility, HHA, there's home health agency, professional services, and other. And as you go through, I just want to draw your eyes to this plot here that suggests that that part of the savings we're seeing is being driven by spending in the post-acute period. Okay, so if BPCI is associated with episode savings for surgical episodes, driven in part by decreased spending in the post-acute period and post-acute care, what about the medical side? So using a very similar difference in differences approach, looking at the same program, BPCI model 2, but now saying surgical episodes may be one thing. What about medical episodes? We looked at several very common medical conditions, including pneumonia, chronic lung disease, sepsis, and we looked at the same thing. And here's what we found. Same forest plot. And what you'll see, I'll draw your attention to, is that in this approach, what we found is that participation in this BPCI model 2 for common medical episodes was associated with differentially greater reductions in total episode spending at about 1.2% episode spending. When we look at, again, those spending components, where is it coming from? It appears that it's being driven, at least in part, by skilled nursing facility spending reductions. That's what that point estimate and the bar to the left of that 0 line seem to suggest. As some of you or all of you may know, one of the well-known strategies for surgical episodes in reducing post-acute spending and rehabilitation service spending is to shift who is discharged to SNFs and IRFs after discharge. We were curious to see if that same lesson from surgical episodes applied here. So this is spending. If you look at what's actually happening with utilization, what you'll observe is actually that in terms of discharge from hospitalization to a skilled nursing facility, there weren't any differential changes between BPCI and non-BPCI participants. what we actually saw was that even conditional on that, where the effect was coming from was actually the number of SNF days. So in the medical episode world, rather than changing the proportion of patients that go to SNF, where we were seeing the effect was really in the length of stay for individuals at those SNFs. Okay, so again, at a high level, I think one could conclude from here that this BPCI bundle payment program impacted episode outcomes, including spending, driven in part by changes in rehabilitation services and post-acute care utilization. And in particular, where we think that the surgical episodes are driven by discharge dispositions, where individuals go after hospital discharge. What we're seeing in this study is that for medical episodes, it seems to be more the issue of how long individuals stay at these rehab facilities once they're there. All right, last thing before I conclude here is that, bundle payments don't exist in a vacuum. In fact, with a proliferation of alternative payment models, they can overlap with other payment models. And in reality, patients can receive care under multiple payment models simultaneously. This can be true for multiple different models, but bundle payments is one prominent model. Another is accountable care organizations in terms of uptake and use across the country. And it's really important from my perspective to understand what happens to outcomes in these overlapping situations. Why? Because I think overlap could lead to either complementary impacts that create additive benefit, or it could actually duplicate or even counteract unintentionally each other in ways that reduce benefit. So for example, you might have care management or care redesign programs in two payment models that kind of add to create even more benefit for patients. On the flip side, if you have duplicative or even counteracting or confusing outreach and engagement through different payment models, that actually may reduce the benefit in an unintentional way. So to really kind of begin to understand this, colleagues and I conducted this additional study where we looked at the association of patient outcomes with bundle payments among hospitalized patients that were either attributed to accountable care organizations or not attributed to accountable care organizations. And we looked at episode outcomes because ACOs, as many of you may know, have a global population-based perspective. So the incentive is targeted around all phases of care for that defined population, whereas bundle payments are focused specifically on that phase of care around hospitalization and post-acute care. So now taking that forest plot I showed you and turning it 90 degrees, what we see here now, instead of the zero line being vertical, you see the zero line being horizontal. So just interpret it that same way now. I'll draw your attention to the left and say that in medical episodes, the highest volume medical episodes, when we looked at post-discharge institutional spending, again, point estimates and bars that are below that zero line suggest differentially greater changes in reductions of spending, i.e. savings, whereas points and bars above suggest more of that outcome. So in panel A here around spending, what we see is that bundle payments is associated with differentially greater reductions in spending, both for the patients that were attributed to ACOs and not ACOs. So the not ACOs is that darker blue. The ACO attributed group is that orange yellow. And when we look at those head to head, ACO versus non-ACO, that's that lighter blue you see there. And the takeaway from that third plot is that there is no statistically significant difference in the degree of episode savings for ACO attributed and non-ACO attributed beneficiaries. Said a different way, it seems like the savings are comparable between the two, and that being attributed to an ACO doesn't necessarily lead to differentially more reductions in post-acute institutional spending. What if we look at that for other outcomes, including rehabilitation services and post-acute care? What you'll see here, using a similar approach, is that there are no changes in mortality for either the ACO or non-ACO group, and by extension, no difference head-to-head for those. You actually see that for the non-ACO group, there is no differential change in readmissions, but there is a differential reduction in the ACO attributed patients, such that when you compare those two, no readmission difference in the non-ACO patients, a readmission difference in the ACO patients, you see that the ACO group actually does better with respect to readmissions, and so on and so forth. And you can see that discharge to SNF or IRF, that there are no differential changes there, and that both the ACO and non-ACO patients saw differential increases in home health use, but the extent of those were similar. Now, given the interest of time, let me just say that if you apply the same approach to if you take that approach and look at SNF length of stay, you see something similar, which is that both groups had reductions in length of stay, the magnitude of which was, comparable from a statistical significance perspective. If you apply that same methodology here to surgical episodes, you see something somewhat similar and somewhat different. So on the spending side, you see that both ACO and non-ACO patients exhibited savings, the extent of which was comparable. Look at that ACO versus non-ACO blue plot there. What you see is different, though, is that here, both the ACO and non-ACO groups had reductions in readmissions, in contrast to the lack of change in readmissions for the non-ACO group for medical episodes. You see that both groups had considerable reductions in discharge to SNF and IRF, increases in home health. And again, the magnitudes comparing these two groups, which is represented here by this third plot in blue, it's comparable. Same thing here. This plot compares these two groups and that were comparable. You see something very similar for SNF length of stay in the surgical episodes. So let me conclude here. What do we take away from this overlap analysis? And what we say in our analysis is that compared to inclusion or care under bundle payments alone, patients that get simultaneously included in both ACOs and bundle payments, those patients, the care was associated with lower institutional post-acute care spending and readmissions for medical episodes and low readmissions, but not spending for surgical episodes. And kind of rolling this all up, this evidence at least is suggestive that receiving care under models such as ACOs may improve actually episode outcomes under bundle payments, i.e. there could be some benefits of overlap. So before I summarize here and revisit the takeaways, I want to just thank the team of individuals who have helped contribute to this work and co-lead this work with me, who you see here. And we'll end where we began and go back to the takeaways. I think we've talked quickly about how bundle payments, in particular BPCI Model 2, has been associated with cost savings and stable quality for both surgical and medical episodes. We touched on how the mechanisms of that, particularly how it applies to rehab services and post-acute care utilization and spending, differs between medical versus surgical episodes. So even though there are benefits, there's a nuance there. And we were thinking about that in the context of individual programs like BPCI. But when you cross that over and think about overlap between bundle payments and models such as ACOs, you see similar things where the mechanisms are different, perhaps, for medical versus surgical episodes, and that inclusion in ACO above and beyond bundle payments may have an effect as well. So lots here. I think this represents work to date, and I would love to see more of this. My group and I are working on it. Thank you for your attention, and I'm happy to field any questions.